Good day everyone, welcome to my channel of lively life snippets. A channel of reliving past memories, be it good or bad, because they make us who we are today. Today I had an idea of converting my case reports into a video, and here it goes. Do enjoy and comment below to let me what do you think of it. After several rounds of editing by my beloved preceptor and me, we came out with this long title. A case of acute kidney injury (AKI), secondary to angiotensin-converting enzyme inhibitor (ACEI), underlying uncontrolled hypertension or interaction between urinary alkalinizer sachet and ciprofloxacin tablets. Till then, I could never imagine having a title this long before. Perhaps it suited case report better because it described a case more specifically.
Please note that any content of this video does not substitute professional medical advices. If you have any health issues, please speak to your doctor and healthcare team. This video is a sample of case reports that I had done during my Provisionally Registered Pharmacist (PRP) training in Malaysia.
Abstract. A 66-year-old male patient was referred for admission with asymptomatic hyperkalemia and hypertensive urgency. He was started on a K 2 weeks ago without a baseline renal profile being taken. Besides, he was concurrently prescribed ciprofloxacin tablets and urinary alkalinizer effervescent granules for urinary tract infection, UTI. AK has various therapeutic indications but is also associated with well-known adverse effects of hyperkalemia and worsening renal function. Close monitoring of serum potassium and creatinine levels are required. Urinary alkalinizer effervescent granules and ciprofloxacin concurrent administration increases the risk of crystalluria. Both factors further burden the kidneys, leading to acute kidney injury, AKI, on chronic kidney disease, CKD. Precautionary steps should be taken to prevent such errors from happening in future. (1s). Keywords: hyperkalemia, AK-induced hyperkalemia, AKI, quinolones, urinary alkalinizer.
Introduction. Acute kidney injury, AKI, is previously termed as acute renal failure. It includes a spectrum of damage ranging from mild decline in function to severe injury necessitating renal replacement therapy. In AKI, renal filtration function can deteriorate abruptly over hours to days. It is usually associated with an increase in serum creatinine or blood urea nitrogen, BUN, concentration. Nevertheless, creatinine and BUN levels may be normal immediately after kidney injury with reduced urine production as the only sign. AKI can happen in patients diagnosed with chronic kidney disease, termed as AKI on chronic kidney disease, CKD.
The Kidney Diseases, Improving Global Outcomes (KDIGO) guidelines recommend the criteria to diagnose AKI as an increase in creatinine more than 26 micromole per liter over 48 hours, an increase in creatinine more than 1.5 times more than baseline, best within the past 1 week, or a decrease in urine output of less 0.5 milliliter per kilogram per hour for more than 6 consecutive hours. Causes of AKI can be classified into 3 groups. Pre-renal causes relate to poor renal perfusion, possibly inflicted by hypotension and severe volume depletion without any damages to the structure and function of the nephrons. Intrinsic causes are associated with cytotoxic, inflammatory or ischemic insults damaging the structure and function of the kidneys like nephrons, glomerulus, blood vessels and interstitial tissues. Post-renal causes include any obstruction in the passage of urine. Common complications associated with AKI are hyperkalemia, pulmonary edema, uremia and acidemia. Up to 10% of hospitalized patient presents with hyperkalemia. 10% of these patients have serum potassium level exceeding or equal to 6 millimole per liter. ACEI or ARB therapy contribute to 10% to 38% of these hospitalized hyperkalemia cases. This case report described an investigation on the cause of asymptomatic hyperkalemia in patient newly started on ACEI and concurrent urinary alkalinizer effervescent granules and ciprofloxacin tablets.
On the 3rd of January 2019, a 66-year-old male was admitted into the Emergency and Trauma Department, ETD, of Anonymous Hospital for asymptomatic hyperkalemia and AKI with hypertensive urgency. Upon arrival, his vital signs were as listed: BP 205 1/100 of a millimeter of mercury, PR 94, SPO 299%, temperature 37 oC, random blood glucose 4.4 millimole per liter. Serum potassium, Urea and creatinine levels were 6.8 millimole per liter, 17.6 millimole per liter and 376 micromole per liter. Estimated SUCL is 17 milliliter per minute, respectively. He appeared a little dehydrated. He had underlying hypertension, diabetes mellitus and CKD. He was also paraplegic and urinary catheter dependent due to a road traffic accident. He did not smoke, drink alcohol or abuse drugs.
Patient was a referred case from Anonymous Health Clinic. He initially presented there for a routine renal profile review as he was newly started on perindopril 4 mg once daily 2 weeks ago for his hypertension. No baseline renal profile was taken. He was concurrently started on ciprofloxacin 500 mg tablets twice daily for a week and urinary alkalinizer sachet 4.2 grams 3 times a day for 2 weeks for suspected UTI. Other medications include multivitamin tablet once per day and metformin 500 mg tablets twice daily. He denied taking any other non-prescription medicines, supplements, vitamins, herbal or traditional products. Patient was prescribed with ciprofloxacin instead of cefuroxime due to previous allergy. Patient claimed that he took all his tablets faithfully but was occasionally non-compliant with the urinary alkalinizer sachets. He was transferred to male medical ward at night on the same day. He was started on amlodipine 10 mg tablets once daily and metoprolol 50 mg tablets twice daily, which successfully brought his blood pressure under control. For his hyperkalemia, 2 insulin chase as well as a 3-day course of oral calcium polystyrene sulfonate powder 10 grams 3 times a day was given. This regimen successfully reduced his potassium level to 4.3 millimole per liter by day 3 of admission. Perindopril tablet was discontinued as it was presumed to be the cause of his ARCI. Furthermore, patient was also diagnosed with transudative pleural effusion, chronic epididymochitis, Klebsiella pneumoniae ESBL plus VE, and new-onset atrial fibrillation in ward. The infection responded well towards a course of ampicillin, sulbactam. No anticoagulant was initiated for his AF due to his premorbid conditions. He recorded a HASB-LED score of 4 and a CHAD-VASC2 score of 3. A differential diagnosis of hyperkalemia due to progression of underlying CKD cannot be ruled out in the ward as his urea and creatinine level did not improve throughout his ward stay. A previous renal profile taken in May 2017 showed urea level was 20.51 millimole per liter and serum creatinine level was 226 micromole per liter. Estimated CRCL is 28 milliliter per minute. On the day of discharge, his urea level and serum creatinine level increased to 18.3 millimole per liter and 493 micromole per liter. Estimated CRCL is 13 milliliter per minute, respectively, which was even higher than on admission day. CRCL was estimated based on assumption that he weighed 70 kilograms and his weight remained fairly constant from 2017 to 2019. Ultrasonography done on the 11th of January 2019 did not reveal obstructive uropathy. Patient was discharged on the 14th of January 2019 with stable vital readings without signs and symptoms of edema. However, his potassium level rebounded to 4.9 millimole per liter and thus was discharged with oral calcium polystyrene sulfonate powder 5 grams twice daily for 3 days and counseled to adopt a low potassium and phosphate diet. He was given an appointment for renal artery ultrasonography on the 21st of February 2019 to rule out possible renal artery stenosis.
Discussion. Asymptomatic hyperkalemia can be due to pseudohyperkalemia, that is normal plasma potassium with an increased serum potassium concentration where usually no treatment is required. Some possible explanations are greater release of potassium from cells during sample clotting, fist clenching, forearm contraction, cell lysis, tourniquet, extreme leukocytosis, thrombocytosis or abnormal red or white blood cells. In this case, possibility of pseudohyperkalemia is very low due to repeated high serum potassium levels. Approximately 40% to 70% of ARCI cases can be attributed to pre-renal causes, followed by 10% to 50% attributed to intrinsic causes and only 10% to 25% caused by post-renal obstruction. 1 Possible causes contributing to ARCI in this patient include newly started perindopril, hypertension or interaction between urinary alkalinizer and ciprofloxacin tablets.
Bilateral renovascular disease is strongly suspected in this patient because he was admitted with hypertensive urgency and his serum creatinine level increased by more than 30% within 2 weeks after starting an ACEI. Even though most patients with similar conditions will have renal artery stenosis, another plausible cause is intrarenal vascular disease. The latter is contributed by hypertensive nephrosclerosis. There are several proposed mechanisms on how ACEI worsen kidney function temporarily. This effect is dose-related. The very mechanism in which ACEI exert its renoprotective effects paradoxically causes renal adverse effects in a particular patient group. In most patients, ACEI promote vasodilation of intrarenal efferent arterioles, resulting in reduced filtration pressure. The latter is thought to be correlated with antiproteinuric properties. However, this is not favorable in patients with severe depletion of blood circulating volume, post-stenotic kidneys or heart failure, as their glomerular filtration relied heavily on angiotensin E-mediated efferent vascular tone. In these patients, pre-renal hypoperfusion induces ARCI. ACEI inhibits ACE, which catalyzes the conversion of angiotensin I to angiotensin II. Subsequently, less angiotensin II is available to stimulate zone glomerulosa cells found in the adrenal cortex to release aldosterone. This impairs renal potassium excretion, leading to hyperkalemia. ACEI-induced decrease in GFR in renovascular disease under most circumstances will resolve after discontinuation of therapy. However, irreversible renal failure may happen, as in the case of this patient. Its pathophysiology is currently unclear. In such patients, decline in renal function is detected weeks to months after ACEI was initiated, hence complicates cause and effect relationship establishment. One of the possible mechanisms is renal artery thrombosis development. This has been usually reported in patients with more than or equal to 95% stenotic lesions. For our patient, this possibility will only be confirmed or ruled out after his scheduled renal artery ultrasonography on the 21st of February 2019. According to NICE guidelines, if the change in serum creatinine exceeds 30% or serum potassium level exceeds 6.0 mmol per liter and no other causes for renal function deterioration like concurrent medicines or volume depletion are found, ACEI should be discontinued and other antihypertensives should be added to optimize blood pressure control. A 65% increase from baseline in serum creatinine level was observed in this patient. Upon admission, patient appeared a little dehydrated but had no complaints of diarrhea or vomiting. No suspicious concurrent medicines were found. Hence, perindopril was stopped, with his hypertension now controlled with amlodipine and metoprolol. The latter also served as rate control for his new-onset AF.
Immune-mediated tubule interstitial nephritis can be classified as intrinsic cause of ARCI. Several reports have associated this with administration of fluoroquinolones, especially ciprofloxacin. In the past, it is unusual, 2 out of 63,000, for patients to develop crystalluria following ciprofloxacin administration. Unfortunately, increase in prevalence had been recorded lately. All reported cases manifested oliguric ARCI and presented for evaluation 2 days to 2 weeks after oral ingestion of ciprofloxacin. This matches our patient. The dose of ciprofloxacin initiated was high in view of an available baseline serum creatinine of 226 micromole per liter in May 2017. According to the product leaflet of ciprofloxacin, the recommended starting and maintenance doses for a patient with serum creatinine greater than 169 micromole per liter was 250 mg to 500 mg every 24 hours, instead of 500 mg twice daily for 1 week. Higher doses may increase the risk of side effects in patients with renal impairment.
Uncommon side effects, more than or equal to 1 in 1,000 to less than 1 in 100, of ciprofloxacin tablets include renal impairment, while rare, more than or equal to 1 in 10,000 to less than 1 in 1,000. Side effects include renal failure, hematuria, crystalluria and tubule interstitial nephritis. Chopra and the team reported a patient whose bilateral ureters were obstructed by calculi made up largely of ciprofloxacin. Elimination of calculi due to urinary supersaturation is achieved by discontinuing the causative medication and starting an alternative. Each 4 grams urinary alkalinizer effervescent granules sachet contains 1,760 mg sodium bicarbonate, 890 mg tartaric acid, 720 mg citric acid anhydrous and 630 mg sodium citrate anhydrous. Citrates in urinary alkalinizer sachets may decrease the solubility of quinolones such as ciprofloxacin, ofloxacin or norfloxacin in alkaline urine. Hence, patients should be monitored for signs and symptoms of crystalluria and nephrotoxicity. Patients should be well hydrated. Besides, use of urinary alkalinizer sachets in patients with renal failure is contraindicated. This could be attributed to high sodium content, exceeding a normal daily salt requirement in sodium-restricted patients. A study was performed by Thorsteinson and the team on 6 healthy volunteers taking 3 different diets consecutively to determine the effect of urine pH in developing ciprofloxacin-induced crystalluria. They were provided varying doses of ciprofloxacin tablet after consuming a diet with sodium bicarbonate to alkalize urine, a diet with ammonium chloride to acidify urine, as well as a regular diet. At high dose of 1 gram ciprofloxacin once daily, 1 out of 6 volunteers on regular diet developed crystalluria. None on the acidified regimen developed crystalluria despite high doses. However, 22 out of 36 urine samples from 5 out of 6 volunteers on bicarbonate supplemented diet had crystals. 21 of these samples had pH more than or equal to 7.3. At a lower 500 mg dose, only 3 out of 6 volunteers on bicarbonate supplemented diet developed crystalluria. The crystals were made up of mostly unchanged ciprofloxacin. In light of the high prevalence of crystalluria in healthy subjects receiving concurrent bicarbonate supplemented diet and ciprofloxacin tablets, this combination in renally impaired patient is strongly discouraged. In terms of antimicrobial activity, a study carried out by Camberry and the team concluded that declined activity due to fall in urine pH is offset by high concentration of ciprofloxacin. Therefore, the theorized negative effect of weakly acidified urine on ciprofloxacin efficacy has minimal clinical impact. In light of this and increased risk of crystalluria, urinary alkalinizer effervescent granules should not be prescribed concomitantly with ciprofloxacin tablets.
Conclusion: simultaneous initiation of ACEI, underlying hypertension and concurrent urinary alkalinizer effervescent granules with ciprofloxacin tablets are possible causes leading to ARCI on CKD. Some precautionary steps suggested to avoid this are taking a baseline renal profile, including an estimate of glomerular filtration rate and serum potassium concentration prior to ACEI initiation, counseling patient to avoid excessive potassium intake from diet, supplements and drugs, starting with low dose of ACEI and titrate up to maximum tolerated dose slowly, tailoring dose of ciprofloxacin in patients with underlying kidney function and preventing concurrent prescription of urinary alkalinizer sachets with quinolones antibiotics. Clinicians and pharmacists should be more vigilant in screening and be alert of this potential undesirable interaction, especially for patients with risk factors like old age, volume depletion, renal impairment and alkaline urine pH more than 6.0. If hyperkalemia happens, rapid management to antagonize the undesirable cardiac effects and normalize both total body and serum potassium could optimize outcomes.
Finally, we had reached the end of my first case report. I had this feeling of achievement of shortening it from 7 pages to 5 pages in Microsoft Word with the help of my respected preceptor. It's kinda different compared to writing a 7,000 words thesis during my university time.
I found it challenging to trim off my crafted pieces. Well, I guess the same goes to decluttering things in my life. Nevertheless, practices make perfect. Thank you for watching Lively Life Snippets, and if you like my videos, hit the like and share button. Don't forget to subscribe, and see you all in the next episode.